Yes, thank you very much for the introduction. And indeed, my presentation, which I realized together with my colleague Alessandra, really wants to go a bit more in depth into the concept of universal health coverage and what it means to make it disability inclusive, or ensuring that there's a specific consideration in regards to persons with disabilities in the concept of universal health coverage. So many of the things that I will present are also reinforcing what has been said earlier by Hannah Cooper, by Alar Kosieza, and really go in the same direction. So when it comes to universal health coverage, of course, it's a very, very debated concept nowadays in the global health agenda. And just for a reminder, when we speak about universal health coverage, we mean that all individuals and communities receive the health services they need without suffering financial hardship. And universal health coverage includes the full spectrum of essential quality health services, including health promotion, prevention, treatment, rehabilitation, and palliative care. The definition of universal health coverage embodies three objectives: equity, quality, and protection. In regards to equity, it is really about ensuring that anyone who needs services gets them, and that households contribute to the health system on the basis of their ability to pay. When we look at quality, it's really about the fact that health services should be good enough to improve the health of those receiving these services. And by protection, we mean that people should be protected against financial risks and ensuring that the cost of using services does not put people at risk of financial harm. If we look at what UHC, universal health coverage, is not, it is not a free coverage for whole health interventions. This would be very nice, but in the majority or all countries, this would not be actually sustainable or even possible for a short or long term. If for some services, universal health coverage might imply that they're really free of charge in some countries, but in general, it really means ensuring that there's no financial risk associated to the access and use of health services. It is not only about health financing. Indeed, when we speak about universal health coverage, we also speak about service delivery, health technologies, workforce, management, governance. And it is not only about a minimum package of health services. The idea really here is to think of universal health coverage as a progressive expansion of coverage and financial protection as more resources become available. So depending on the fiscal capacity of a country, we should start from an essential package and then expand as the fiscal capacity grows. When we look at the foundations for universal health coverage, it is clearly something that is embedded in the human rights frameworks. So health is a fundamental human right. This is something that is recognized through the Universal Declaration of Human Rights, the WHO Constitution, and several international conventions, including the Convention on the Rights of Persons with Disabilities. In 2005, the World Health Assembly adopted a resolution on sustainable health financing, universal coverage, and social health insurance, which really frames the concept of universal health coverage. In 2015, universal health coverage was embedded in the Sustainable Development Goal framework under the Sustainable Development Goal number 3, which is about ensuring healthy lives and promoting well-being for all. There is a specific target, which is target 3.8, about universal health coverage. And in 2018, the Declaration of Astana played a very important role in strengthening primary health care towards the objective of universal health coverage. Finally, 1 year ago, 2019, the United Nations adopted the Political Declaration on Universal Health Coverage, which is also an important milestone to really accelerate progress towards the realization of this principle. What about persons with disabilities in universal health coverage? So what are the relations also between the rights of persons with disabilities and this concept of universal health coverage? Well, as I said before, universal health coverage really is built on the principle of the right to health for everyone. And the UN Convention on the Rights of Persons with Disabilities has a specific article, which is Article 25, which requires states parties to ensure that all persons with disabilities have the right to access quality health services with no discrimination. If we look at the Agenda 2030, that also contains the 17 Sustainable Development Goals, there is inclusion of persons with disabilities therein. Some targets and some objectives really refer specifically to persons with disabilities, but in some others, there's no specific reference, but the overall 2030 agenda speaks about prioritizing vulnerable groups, including persons with disabilities, and places a great emphasis on the core principle of leaving no one behind. The 2019 Political Declaration of Universal Health Coverage has specific mentions to persons with disabilities in its text. And it requires to implement disability responsive interventions, to remove barriers to access for all persons with disabilities, and also to train health workers on disability, to be able to actually address the needs of persons with disabilities, communicate with them, and making sure that care is offered to everyone. So global recognition of persons with disabilities within universal health coverage frameworks exists, but this right does not often translate into practice. And this comes back to concepts that have already been presented by other speakers about the needs and barriers faced by persons with disabilities. So as mentioned also earlier, the general needs, health needs of persons with disabilities are the same as everyone and might be addressed by primary healthcare practitioners very often, but persons with disabilities might also have additional specific needs related to impairments or comorbidities. For this reason, they might have higher, and in general, this is the overall statistics, is that persons with disabilities have higher healthcare needs, but also greater barriers to access healthcare. And these barriers encompass physical, communication, attitudinal, and financial barriers. So inaccessible communication, infrastructures that are not accessible for persons with physical or sensory impairments. Attitudinal barriers might imply also stigma and discrimination, or anyways, negative perceptions within the health system, but also within communities around persons with disabilities. And financial barriers that I will explain more in detail later, but that in general are seen as a major barrier indeed to access health services. As a result of all of these, persons with disabilities are two times more likely to find healthcare providers' skills and facilities inadequate, 3 times more likely to be denied healthcare, and 4 times more likely to be treated badly in healthcare facilities. And what we know is also that when disability intersect with another exclusionary factor, which might be gender, age, migratory status, sexual orientation, these barriers can become even bigger, and they can really shape access to and experience in healthcare. So when we look at persons with disabilities, we also need to consider different exclusionary factors that come into the play. And if we look closer at the financial accessibility, the first consideration already is that persons with disabilities and their households are more likely to live in poverty. Disability is both a cause and a consequence of poverty, in the sense that people who live in poverty are more likely to experience disability, And persons with disabilities are more likely to live in impoverished conditions. 80% of persons with disabilities live in low and middle income countries. So there is already a strong correlation and interaction between disability and poverty. And also there are financial barriers indeed to access health services. So as a result, 50% of persons with disabilities cannot afford healthcare, and they face a 50% higher risk compared to persons without disabilities of facing catastrophic healthcare costs, meaning costs that are so high that put the person in a condition of poverty, of impoverishment. Persons with disabilities also face barriers, for example, when we look at insurance schemes, which are a very common mechanism to protect against financial risk. Very often this is due to lack of accessible information in regards to these insurance schemes, but there are also discriminatory policies that on pre-existing conditions that actually hinder the possibility for many persons with disabilities to subscribe, to enroll in these insurance schemes. Humanity and Inclusion has a long-lasting experience working in the field of physical and functional rehabilitation in the many low and middle income countries where we operate. So I will just go a bit more in depth with an example on rehabilitation. Because actually, yeah, rehabilitation is not just for persons with disabilities. Of course, anyone might need rehabilitation at some point during their lives. It's really the essential health strategy that addresses limitations in functioning. So everyone can be concerned. But for many persons with disabilities, indeed, rehabilitation is an essential health service that might require also a certain continuity in terms of care over time. And in terms of rehabilitation in universal health coverage, it is clear that rehabilitation is part of universal health coverage. This is also set in the different policy frameworks because it's recognized as a core health strategy along with promotion, prevention, treatment, and palliative care. However, if we look at the reality, we notice that rehabilitation services are often under-resourced, underdeveloped, and their financial coverage is variable, but very often absent, in particular in low and middle income countries. Humanity and Inclusion has carried out over the years a number of studies which we call IFAR, and the IFAR is an acronym that means Improving Financial Accessibility of Rehabilitation Services. And these studies want to provide an economic analysis of the access to physical and functional rehabilitation in low and middle income countries. So far, these studies have been carried out in more than 10, 12 or 13 countries. But recently, last year, we compiled 9 of these studies into one compendium, let's say. So we produced a fact sheet out of these many studies to really try to understand across the different countries, what are the commonalities when it comes to financial access to rehabilitation? What are also the lessons learned, and what would be the key recommendations for the way forward? So we used 9 of these studies in Afghanistan, Laos, Vietnam, Cambodia, Madagascar, Rwanda, Burkina, Haiti, and Bolivia, to really try to see how to combine these findings and see what really emerges from a more global perspective in terms of financial accessibility. What the key findings that I'm presenting today, I'm just going to present a few of them. Well, I would say one of the most prominent one is that in 6 out of the 9 countries examined, rehabilitation services represent catastrophic health expenditure. And an example is that in Burkina Faso, the average cost for a set of rehabilitation sessions is 3 times bigger than the amount that actually represent catastrophic health expenditures. Another finding is that health financing schemes, in particular private insurances, often exclude rehabilitation services and assistive technologies or devices from the coverage, from the covered packages of care. And one example is that in Laos, not even a quarter of the population is enrolled in public insurance schemes. Also, the level of investment in rehabilitation services is inadequate. Sometimes it would not require a big investment, but still there is too limited allocation of resources for rehabilitation. In Haiti, for example, the investment to train prosthetists or orthotists is estimated at 0.54% of the budget of the health ministry, so something that is not too big, but yet it is not happening. There is significant shortage of rehabilitation workforce. These studies tried to estimate how many rehabilitation professionals were missing, and we come to an aggregated number across the 8 countries, which is more than 200,000 physiotherapists missing and more than 600 prosthetists or orthotists missing across the 8 countries that we studied.
Valentina Pomatto, can you come to an end because
yes, this is my last slide.
Okay, thank you.
From these, we have recommendations, and the recommendations are listed here and in the next slide about making accessible and culturally sensitive communication, building the capacity of health service providers on disability inclusion, covering disability-specific services and rehabilitation in these priority packages of care. Disaggregation of data is also very important by disability, age, and location, really to understand the needs, but also to understand the experience in accessing health services. The participation of persons with disabilities and the representative organizations is crucial for inclusive health. And when it comes to funding, the key issue is not only to do more, but also to do better. And this can be done both through domestic funding. Of course, it's very important. It's crucial that governments bear the responsibilities, but also international aid can be part of the solution. And in doing this, what we always recommend is a twin-track approach. On one side, promoting inclusion within mainstreaming actions in health system strengthening, but on the other side, it's also important to dedicate a specific stream of funding to the most marginalized groups, including persons with disabilities, and earmark disability inclusion to really track how funding are spent and how much actually goes to persons with disabilities and to other vulnerable groups.
Okay.
Thank you very much.